Welcome all of you to this live program in Orthopedic Principles. Today, our guest of honor is Dr. Lourenco Peixoto from Brazil. Dr. Peixoto works at the National Institute of Orthopedic Surgery since 2007 and leading the hip surgery area since 2018. He specialized in hip surgery with special interest in sports-related injuries. In 2012, he did a one-year fellowship with the Stedman Philippon Research Institute with Dr. Mark Philippon. His research interests are biomechanical aspects related to preservative surgery of the hip, arthroscopic treatment in skiffy patients, pubalgia treatment, and minimally invasive total hip arthroplasty with a direct anterior approach. In 2015, he was elected president of the Hip Surgery Society of Rio de Janeiro for a two-year period. In 2018, he was chosen as the chief of the hip surgery area of the National Institute of Orthopedic Surgery. If you've noticed, Dr. Peixoto has delivered a lecture on a channel and it's already reached a huge audience. And today it's my great honor to bring back Dr. Lourenco Peixoto for this wonderful live program. Over to you, Lourenco.
Hello, everybody. Thanks for the invitation. It's a big pleasure for me to join you today. And my topic gonna be hip arthroplasty complications and salvage. I like this topic. It's a very exciting talk. So first of all, I would like to show you what's the complications menu. What are the most common complications when you do a total hip arthroplasty? So I bring this paper, it's 2009 paper, and I intentionally bring it. It's an old paper, but just to show you a few characteristics of that time complications. At that time, in 2009, in US, you can find instability as the first complication to 22% complications, followed by aseptic losing and infection. That's a retrospective study performed by Dr. Daniel Barry at that time. So now we come to these guys' registries, and you're gonna see that infection now is the top #1 cause of revision after total hip replacement surgery, elective total hip replacement surgery, followed by instability and aseptic loosening. So instability was first, now is second, and aseptic loosening was the second, now is the third. Probably because something happened in this period of time. We now have bigger femoral heads, we have dual mobility, better approaches, and probably that's the reason why we have less instability nowadays. As the same, we have less aseptic loosening because the materials are probably better, and we are seeing less of these kind of complications. But infections, unfortunately, it looks like it's the same. One very interesting point in this topic is that if you see when the total hip replacement primary fail, most part of them, they fail in the first 3 months. So 54% of them have to come back and do a revision surgery in the first 3 months after surgery. And that's a very interesting characteristic of this group of patients. And we see, when we see the main causes of revision in the first 3 months, we have a different aspect and a different causes of failure. We still have infection at first, but then comes fracture. So fracture is the second most cause of failure after total hip replacement when we analyze the early period after surgery, and then comes instability. In our reality in Brazil, what's our menu? What happens with us? We studied 1,800 patients submitted to elective total hip replacement between 19 and 20. We excluded patients under 50 because we want to compare how the outcomes of people older than 70 years old compared to people between 50 and 70 years old. So we excluded the young people. We excluded very old people. We excluded hematologic diseases, neck fracture, tumors, and loss of follow-up. So we had 900 patients by the end. And that was the configuration, 75% less than 70 years old, 24% older than 70 years old. And we have, when we consider all the complications, patients under 70 years old had 7.8% of complications compared to 12.9% complications. And there was significance between these numbers. So that comes to the point that when you talk about complications, there is a lot related to the patients. So of course, older patients brings with them lots of commorbidities. So if you want to talk about complications, you need to ask what patients are we treating. So older patients have more complications. There is no doubt about that. And when we analyze the kinds of complications, infections is the number one. It's a 1-year follow-up study. Infections is the number one, like in the other studies. We had instability, and fracture comes next. Just to show you a little bit of our results, you see that urinary tract infection increases the length of stay in the hospital much more in the older group of patients. And that's a very interesting finding. As well, tabagens. People older than 70 who smoked have a much more longer length of stay in the hospital after a total hip replacement surgery in our reality. So let's talk about the complications, beginning with instability. Instability is a very difficult to deal with because it's a traumatic situation. It creates some tension between the relation with the patient and the doctor. So there are some risk factors we need to have in face. We need to know people older than 80 years old, female gender, neuromuscular disorders, cognitive disorders, alcoholism, and prior hip surgery. In terms of surgical technique, the surgical approach looked like to have some kind of relationship with instability. If you repair the capsule or not, soft tissue tension, and other points as well. When you talk about instability, we need to look at the history to understand what happened. In the beginning of the century, we had increased use of 32 millimeters femoral head or bigger. So we saw a decrease in the index of dislocations in this population. So we had in average 4% of dislocation in the end of the 90s. So we came to around 2% by the end of 2010. And that's probably related to the use of bigger femoral heads, because they are available for us. The industry is able to produce bigger femoral heads, and people are using it more. So that's a historic factor. In terms of the patient, we need to think about obesity. We know that the more obese the patient is, the more chance he has to develop a dislocation of his total hip arthroplasty. It's a paper that studies lots of kinds of complications. If you take a look at the histograms, you're going to see that the more obese the patient is, the more transfusions, the more infections, the more almost everything happens with them. And for dislocation, that's the same. Another very interesting topic we need to talk about is the spine surgery. So we know now that the spinopelvic balance is very important to hip instability. And we know that if you have a prior spinal surgery and you perform a total hip replacement, you have an odds ratio of 2.96%, not percent, 2.96 increased chance for developing a dislocation of your total hip replacement. So you must be aware if you are doing a total hip replacement in a patient who has a lumbar arthrodesis, you need to study the pelvic balance and think about using some more stable components to avoid these kind of complications. So in history, we are trying to avoid instability. We learned that the bigger the femoral head, the best in terms of instability. And then the industry started creating bigger and bigger and bigger femoral heads. And in the beginning of the century, we had these large diameter femoral heads. And we start seeing some troubles related to this kind of implants. The one new thing was the trunion, where we did not know that happens before these long, large diameter femoral heads. So we started using these implants and we started seeing lots of local tissue reactions. And part of these reactions were related to the trunion wear. And that's something that showed us that bigger is better is not true, not always true. And there are some biomechanical studies that shows that femoral heads bigger than 36 millimeters do not aggregate more stability because you start having extra-articular impingement. So it doesn't matter if it's a 46 femoral head, it looks like that stability is quite similar to a 36 millimeters femoral head in average. And that's not something related only to the metal large diameter femoral heads. We've seen some catastrophic failure related to the trunionosis with standard stands as well. Most part of them 36 millimeter and longer, +4, +5 stands. These are a series of cases of catastrophic failure, but that demonstrates that they're gonna be probably there are some trunions suffering, not failing like this, but causing some kind of debris, metal debris inside the joint. So we must be aware of this. We did it in our institute, some of these large diameters femoral head metal implants. They perform well in reality in the first few years. And then we start seeing after 10 years post-op in average, this kind of aseptic loosening of the acetabular component. So that was an acute failure. He was doing perfect. He had no complaints. And look at these findings, intra-op findings. This is the gluteus medius, big destruction of the muscle. Look at the trunion with this wear over there. And so we decided to revise to a standard metal on poly component. And I left the stand. That's a Zimmer CLS fixed stand. So I decided to keep it. So that was a really sad to see that big destruction over there. That's another case, around 10 years post-op. That's a secure fit striker stand and large diameter head metal with some osteolysis, and it was loose in reality, the acetabular component. We need to revise it. I revised it to a revision stand with a larger offset because this secure fit stand, that primary one, did not have a lot of offset. And then after switching the acetabular component, it was unstable. So we need to remove it. And I need to do a trochanteric osteotomy to remove it. The metal problem is not something that happens only with the large diameter femoral head. That's That case is a funny, interesting case. It's a ceramic on ceramic trident secufit component. And they had, at that time, it's a third generation ceramic, that's the Biolox 40. And they had that problem with break of the ceramic. So the striker decided to create that liner with a metal behind it, so to protect the ceramic not to break. So then there is an interface, metal interface behind the liner. In this case, he's 15 years post-op, and then he starts complaining of pain. We saw some kind of osteolysis in the zone 1 and 7 of the femur. The images show some osteolysis. I did not understand what was going on. I believe that in this case, there was some kind of impingement between the femoral neck and the liner, because they have that liner with a metal. So when when there is a contact between the femoral neck and the liner, sometimes it generates some debris from the metal, but intra-op, we could not see any impingement between the neck and the liner. And we attribute these findings to the backside of the liner. So we remove it, and we send it to a retrieval analysis to understand what happened. There is like this sponge-like tissue all around the joint, and I leave the stent, and I use double mobility in this case, a G7 Zimmer double mobility to reconstruct this hip. In terms of durability of these femoral heads, we see that that's safe to use a 36 millimeters femoral heads. They have a less index of revision over time when we compare to 28 millimeters femoral heads. So that looks safe to use these bigger heads until 36. And that's how the world is working. We have data from all over the world, but it's American Joint Replacement Registry from 2020. And we see that over the years, they are using more 36 millimeters femoral heads. And the one interesting thing, and it's a new thing, they are using now more dual mobility. That's the red line over there. It's almost in 10% of their elective total hip arthroplasties. So that's a lot. And you see by age, the double mobility are almost 10% of these cases. And that's interesting to see that it's 8.1% of the patients under 50 years old. That's a lot. People in US are really afraid about instability. And I would expect that they use it more in older patients. Over 90, they use 9.6%, but not in younger patients. That's an interesting finding, but that's something that's happening over there. With that case, just to remember that stability, there's no prosthesis that avoids completely 100% instability. That's bipolar arthroplasty. And what's funny about complications is that sometimes one complication brings another. I don't know if you guys have ever seen that. My colleague tried to put this prosthesis back to the place, and then there was an intra-prosthesis dislocation. That's an interesting case. That's another situation, bad tensioning, arthroplasty, bipolar, that evolutes to dislocation, so you need to revise it. So bigger femoral heads, it's not a guarantee you won't develop some kind of complications like instability. Instabilities are really, really difficult sometimes. We follow the original paper Lourenco published it in 1978 our guidelines for a correct placement of acetabular component. It's 40 degrees abduction, 15 degrees anteversion. But of course, nowadays, you know, that's not simple like that. But anyway, in this case, we did it looks like great, you know, in the left neck safe zone, looks good. There was arthrosis, there was not a femoral neck fracture. The patient had no neurological issues. So then the first dislocation, so we bring her to the hospital and place the prosthesis back to place, and then it comes out again. She was a good patient. She understands what's happening. And then, okay, let's revise it. Probably we need to get more tensioning of the soft tissues. So use the plus 12 femoral head. And of course, inter-op, we tried all the range of motion and everything was working fine. And then it comes out again. So, and then we decided to use a double mobility, and now she's everything's working well. So we don't know what happened, but now we have at least for these situations, I think the double mobility is a good way to work with. That's another case. She had a previous spinal surgery, and she had that prosthesis operated in other hospital. So I revised it, and I cemented double mobility liner in the metal, in the old metal. It looks like good inter-op, but still dislocates. So double mobility dislocates too. That's a good example. So we revised it again. We re-cemented the new stand over there, and she dislocated again. So you needed. We used a constrained liner at last. That's the final point. We don't like using constrained liner usually, just for exceptional cases like this one. Let's change the topic. Now let's talk about periprosthetic fracture. There is something interesting out there, is that the papers show that cemented stands fracture less than non-cemented, but still people use more non-cemented than cemented stands in most part of the world. That's a paradox, and that's funny to see this paradox, this kind of behavior people have. Me, myself, I prefer using non-cemented stands as well. But that's not what the data shows. I was talking with a colleague from Endo Clinic, and now they switch their protocols. They are using cemented stands in patients over 75 years old. Maybe it's a good way of working. In US, when you see they use almost for everyone uncemented stand, even in the older stratum of the population. They are using more cemented stands, but it's still in 5.8% of all femoral implants used in that country. Even in UK, when you see that National Joint Registry from 2020, you're gonna see the blue line is the uncemented total hip replacement. That's a lot, even in the country where they advocate a lot of cemented prosthesis. And that brings us to the problem, the periprosthetic femoral fracture. We know there's a classification from Vancouver. That's easy because that's help us to treat these patients. So if you have a B1 fracture, that means that stands fixed. B2 fracture, that means that stands loose. And B3 fracture, you have a bad bone quality. C type is distal to the stand, and the stand's fixed, so you have to fix the fracture. And I would like to bring a new concept, a new view of this classification. That modification comes from the Exeter guys. And that's interesting because sometimes when you have a B2 fracture, the stand is loose, but the cement mantle is good. You are able, in this situation, to just fix the fracture and let it go. So sometimes you see that kind of situations. That's an example. That was a good, we had a good cement bone interface. We had this kind of fracture and you just fix it and we have a good outcome. That's another very nice example. This is a 90 something years old man. He's a Second World War survival, and who operated him was Dr. Harding. So he's like a 40 something years old post-op, very low demand patient, and he fall down and developed this fracture. That right X-ray with the drawing is that because I asked the traumatologist his opinion. That was his treatment option at that time. So he came to fix this fracture, and we decided just to fix the fracture with no plates. He's a very low demand patient. The bone cement is still good, and and he had a good outcome. So I showed this case just for you to be aware that sometimes B2 fractures can be treated when we have a cemented stand with just fixation of the fracture. That's a B1 fracture, periprosthetic fracture with the stand fixed. That's how we do it. It's like a trauma surgery. When you have a B2 fracture, if the stand is loose, that's a Smith-Nephew polar stand. So we had a greater trochanteric fracture. So we use a distal fixation titanium stand, Wagner SL stand with a trochanteric plate associated. That's another B2 fracture where we remove the cement and use this distal Wagner SL fixation stands. Another B2 fracture after subsidence of non-cemented ML taper Zimmer stand. And then we just fix it with a distal fixation stand. Sometimes we have an intra-op fracture. That are the most common fractures during non-cemented total hip arthroplasty. Most part of the time we fix it, and we have good outcomes after doing that. We don't need a distal fixation, these kind of situations. Mainly when the fracture is proximal to the lesser trochanter, just fix it with cables, and then we use a proximal fixation stand, and most part of the time they go well. Another B2 fracture with a distal fixation modular ZMR fixation stand, and that's a B3 bone loss periprosthetic fracture on AMT Johnson stand, cemented. So we revise it to a distal fixation stand. But sometimes things are not so easy. Look at this patient. We did this total hip arthroplasty. I did this case. I saw no fracture. That's a post-op X-ray, no fracture at all. And then after 2 months, he came back to the office with this calcar fracture. We bring him to the OR. We fix his fracture, and everything looks good at this time. So then we start seeing the bone, the calcar starts vanishing. You cannot see it anymore. Look at his calcar. He was doing good, but the bone was just disappearing. That's funny. And after 1 year, he developed some kind of infection. There was an infection already, but no clinical signs. So he had an infection after fixation of his fracture. So we had a big bone loss at this time that was hard to remove the stand. So that's the final result. And the infection was cured. And after 8 months, the bone was appearing again. That's an interesting case I would like to share with you. Nature sometimes help us. So we fixed the fracture, he developed infection, we had a big bone loss, and then we have the bone back again to the proximal femur. That's interesting. In that case, is bringing me to the fact that sometimes non-cemented stents subside inside the femur. That's something we do not wish that, like acetabular stent, the concept is as far as it subsides, the more it fixes to the femur. But that's not the same for uncemented stents. You see that the more they subside, the more they fail. We don't know what's the calcar support paper function. There are lots of guys using this calcar support nowadays, but we are not quite sure if it's good or not for the survivorship of these stents. So we decided to study these kind of characteristics because we have lots of kinds of stents. Most part of them are these single wedge stents in the left. In the doubles wedge stents in the right. These are the most common stents used nowadays. The two concepts, the more used concepts used nowadays. So that's hard to compare them because patients are different, bone qualities are different, level activities are different. So we decided to compare the patients. We did a bilateral total hip arthroplasty with different designs, different concept stents, and compare the subsidence between the two of these stents. So we had 47 patients with bilateral total hip arthroplasty with different designs. All of them were Johnson stents. One was Summit and the other one was Corio. For all of the case, 32 months follow-up. They were 6 years age. And we observed that the subsidence in the single wedge Corio stent was much less than the Summit stents. And that's funny because the Summit is the concept of full and fill the canal. So it's a broad stent. It occupies all the space in the metaphyseal area of the femur. And still, the Corio stents tend to subside less than Summit stents. And probably that happens because you need to ring distally when you use the Summit stents. So it's more aligned in the profile view with the femoral canal. That's different for the single wedge stents, where you use just broaches. They are shorter, and in the profile, they touch 3 cortices. So they are locked in the profile view. Probably that's the reason why these stents subside less than the others. And we have experience with these short stents, and they subside as well. This is a case of a Meta B Brown stent, and it subsides. It looked at that it would be. I was hoping that it subsides and get it locked in the femur, but it did not happen. So we need to revise it. So when you talk about periprosthetic fracture, we talk a lot about non-cemented against cemented stents, but still we have difference in this different segment. When we talk about non-cemented, we have different stent designs, and that's what this paper, the goal of this paper was to research which kind of design fractures more or less. So the conclusion is that non-cemented stents, single wedge and double wedge, have more femoral fractures. These are 3-fold increases in periprosthetic femoral fractures when you compare to anatomical, fully coated and taper rounded stents. That's interesting. So in the universe of non-cemented, we have difference. And that's the same for the cemented. Acetabular-like stents have more fractures in the femur when you compare to the composite beam stance like the Chernley stance. That's the periprosthetic fracture analysis. We know that long-term follow-up, the acetabular-like stance, cemented stance, have a longer survival when you compare to Chernley-like stance. But when we analyze periprosthetic fracture, that's what we found. Acetabular stance fracture more femur than the others. We don't talk a lot about acetabular periprosthetic fracture. That's probably because we don't see most part of them, and also because most part of them get cured by themselves, because most part of them are intra-op fracture with stable prosthesis, and then probably the patient have some pain, you don't realize it happened, and then it get fixed itself after a few months. So that's a Pascarella classification of this periprosthetic acetabular fracture, and he divides it in the intra-op. If the prosthesis is stable, you don't do anything, or maybe you increase the primary stability with screws, or if the prosthesis is unstable, you need to do something, fixation with plates, maybe using acetabular ring with screw, maybe implant revision. And if the second, if the fracture is post-op or it's a traumatic fracture, so you need to understand if the prosthesis is stable, if it's unstable, if there is some kind of osteolysis associated with it. So that's the algorithm he proposed in this paper. So I'm going to show you a few cases. That's a basal cervical fracture. A colleague of mine, he was in his beginning in his career, and he removed too much the acetabulum in the left side, and probably he caused some kind of fracture of the lamina quadrilatera, and the acetabular component start to migrate inside the pelvis. That's a very interesting case. It's that splastic hip. I did it at first the right side and then the left side. I was running a study in my institution. So we were doing CT scans pre and post-op in all primary total hip arthroplasties because we want to study the version of our components. So that's the CT scan, the D1 post-op of this patient. You see no acetabular fracture. I have the other views. I can guarantee you nothing happened with the acetabulum. And then when she came back 6 weeks after surgery, there was acetabular fracture over there. The acetabulum was stable. Thanks, I put some screws over there. She denied any kind of trauma. And that's interesting to see that fracture without trauma, and there was no fracture in the day one after surgery. So probably that was a stress fracture because of the tension of the prosthesis over there. So that's I would like to share with you. This is a protrusion when a colleague of mine put some graft in the bone behind the acetabular cup. And then you see a fracture, stable fracture with good evolution. That's a patient that was operated in other hospital. He came with this X-rays with acetabular fracture, and it healed. But then after healed the fracture, peracetabular fracture, he developed that type C fracture, periprosthetic fracture of the femur. So this patient developed 2 periprosthetic fractures in his lifetime, and we just fix it. Another issues I would like to share with you, we are facing some of these cases, is the dissociation of liner. For non-specialists, they you can think it's a instability, but in reality, that's a dissociation of the liner. We've seen some cases out there published. In this series of cases, they show 1.1% of dissociation of the liner in average after 37 months after surgery. In a few situations, it's a good idea to cement a poly in the metal if you want to guarantee it's not happening again. That's a pinnacle patient of us. She had that kind of dissociations. She took a lot of time to look for help, and that's the result. A lot of metallosis, a lot of destruction. That's a catastrophic situation. That's another case. That's 16 years post-op patient. He was doing good, and then he had an acute problem, and he came to the office, and the liner just was loose from the metal. That's another case. It's dysplastic Croy 4 patient. So he had a progressive liner problems and disengagement as well. Look at this metallosis, and the liner was loose, and the femoral head go through the poly and the metal back and cause a big destruction. That's another case of a patient with a dissociation of the poly. Look at this, how she came for us because she was worried about this noisy. So that was dissociation of the poly as well. Ceramic poly, another summit pinnacle ceramic poly dissociation. All of these implants, we send them to retrieval analysis to see what's happening. When it comes to aseptic loosening, sometimes like this case, this was a Crow 4 splastic hip. We had to use a structure graft in the roof, and then probably in this case there was not enough contact between the prosthesis and the native bone, so the prosthesis started migrating progressively. After 80 years after surgery, the contact probably was not enough between the prosthesis and the host bone. We've seen some problems with aseptic loosening in people who are doing the direct anterior approach. So the surgeon delivered this prosthesis very vertical, and then it started to migrating proximally. If you see, there's a trochanteric fracture associated with this. So we are seeing lots of problems related to direct anterior approach, and that's the solution. That's when I came and did her revision surgery. That's a very tricky situation. This is a Down syndrome patient. She had a few surgeries before. She was obese, and I put this Smith-Nephew implant, good quality with screws, and that was not enough. So that was an aseptic loosening of this acetabular component. So I need to revise her with a cage, with a cemented poly, and I kept the stent. So then she developed infection. So I need to revise the stent to a cemented stent with antibiotics. And then the infection was cured. She was good, but she developed sciatic neuropraxia. So sometimes it's that comes together, the complications. That's an interesting case of a post-op of a acetabular fracture. So it was good at first, and then the acetabular component started loosening, and then by the end it was infection. You need to revise it with this kind of spacer. Some aseptic loosening of the femoral stents are related to the bad quality of this implant. These old implants had a bad interface for osseointegration. So I revise it easily. The stent goes out with no problems. but that's for us to see how better we are nowadays with our new implants. Cemented stents lose to get loose also. So that's a case of a femoral neck fracture, hybrid, total hip arthroplasty, who developed subsidence. And then I revised it. I cemented a double mobility liner, and I used a distal fixation stent. And the distal fixation stent suffered a subsidence, and then he dislocated. So I revised the stent, and now he's good, feeling good. Really bad biomechanics, really bad knee. So I'm glad I used the double mobility to increase the stability of these weird biomechanics of his lower limbs. That's for you to just to show you that sometimes we have a good surgery in the sciatic neuropraxia. It's a 4 months post-op. She's showing that she just recovered from that lesion, but that's some kind of complication sometimes we have. I've been doing some direct anterior approaches. She was doing good, really happy biomechanically, but she had that kind of numbness of her thigh. So look at the area of lateral femoral cutaneous nerve injury. So the surgery was okay, but now she has this area of numbness. Just for you to know, because in papers out there, they say that it's a minor complication, but sometimes for the patient, it's not. That's I'm studying this group of patients when we deliver some screws inside pelvis. I'm trying to observe if this is a problem, if they are in the safe zone, it looks like it's not a problem. So, but you can see it in the X-ray, and something interesting happened to me. I did a total hip replacement in a very young girl. She was 18 years old. She was doing good, perfect, no complaints. And his father pointed at the screen and asked me about the intrapelvic screw, if there was some problems related to it. And thanks God she was doing great. She had no complaints. But imagine if she had some kind of discomfort, some kind of pain, maybe the family would begin linking one thing to the other. So we need to understand and publish these findings with these intrapelvic screws and show people that most part of the time we have no problems related to it. So that's a next paper we are working. That's to remember that we have lots of vessels around the acetabulum and also nerves close to the places where we deliver our screws. So that's it. It's a big chapter. There are lots of complications. My goal here was to show you a few interesting topics. So again, thank you for inviting me. Bye-bye.
Thank you, Lourenco, for this very exciting presentation. Lourenco, maybe you can stop sharing and try switching on your video now.
Are you seeing me?
No, I can't see. I'm sorry. It's okay, no problem. A few questions, Lourenco.
Yeah.
Now, so what is your favorite head size? What is the normal head size? You said that the 36 millimeter head is the one that's being commonly used, right? So what about you?
Yeah. In Brazil, we have a lot. Our population is not very tall, so in average for a woman, we use 50-48 acetabular components. So in this range of size, the bigger you can use is the 32 millimeters femoral heads. For men, in average, you use 54 millimeters acetabular components. So In men's, we are allowed most commonly to use the 36 millimeters femoral heads. Just a curiosity to share with you, but in my practice, the bigger the best. I try to use the bigger I can. So the bigger the best until 36.
Thank you, Lourenco, for that. And what is your preferred bearing surface? For example, you mentioned a lot of bearing options. There's a metal on poly, ceramic on ceramic, ceramic on poly. So what is your preferred option?
Yeah, I think ceramic on poly is a very, very safe choice because for young people, we see that that's a long-term survival that's really good. We don't have squeaking, and we have the facility of using neutral poly, poly with a lip, poly introverted. So we have more options, and also it's easier to accommodate the poly in the metal bag. Imagine impacting a ceramic liner, and there is a screw behind or some bone inside the metal bag. So maybe you have problems with it if you do not accommodate the liner correctly, the ceramic liner. So I think the poly is more forgiving, and also we know that the ceramic head cause less trunionosis. So that's a good option for me for the younger, because it causes less trunionosis, and the liner, we have more options. And for the older, it's a good option as well because of the trunion, to no squeaking. And most part of the time, older than 70 years old, I use metal on poly. Less than 70 years old, I use ceramic on poly. That's my options.
And do you have the same options available with the metal on highly cross-linked poly? You use a highly cross-linked poly, isn't it?
Yes, yes.
And if you compare a ceramic on poly with a metal on highly cross-linked poly, what do you think is the difference? Do you have the same options, like you said, anti-watered, the lid, constraint liner? So do you have the same options with the metal on highly cross-linked?
Yes, we have the same options in the metal and highly cross-linked for sure. We see that today the wear of these metal and highly cross-linked combinations are really low. This is safe to use it, but we have lots of information out there. Patients come asking for ceramic femoral head implants, so that's hard sometimes to convince them, to use a metal femoral head because of the internet. That's something that's not changing anymore. So they have these informations, but for me, the metal on ceramic, the metal on poly, it's a safe and good option, except for the trunion. We don't know because sometimes we have infections with negative cultures, negative inflammatory tests. Are these infections caused in reality? Are then local tissue reactions caused by the trunion? So I don't know. Ceramic femoral heads, I think they are safer, more because of the trunion than because of the durability, because highly cross-linked poly works really well, even with metal heads.
Thank you, Lourenco, for that. Lourenco, we are also joined by Loy Al Khatib. Loy is an orthopedic and sports surgeon based in Dubai. Loy, welcome to the program.
Yeah, hi guys. Can you hear me?
Yeah, we can hear you well. Loy, your questions to Lourenco, please.
Yeah, thanks so much, Lourenco, for this presentation. Although I am a sports medicine guy, I'm more interested in shoulders and knees. But do you have any advice for the surgeons, so low volume surgeons who do this stuff, or not on a daily basis, just doing being informed? Do you recommend doing cemented and cemented stem, or do you believe that cemented stem will have a lower complication rate compared to a cemented stem? What's your advice for low volume surgeons?
Can you repeat the? I think the microphone is. I can't hear.
Loy, your
Well.
mic is not clear. I think the question is, do you have, what is the difference between uncemented stem versus cemented with respect to complications? Am I right, Loy?
That's true. Can you hear me now?
Yeah. So, Lourenco, that's the
true,
question.
especially for the low volume surgeons, as me, as like I'm a shoulders and knee surgeon, and I'm doing not a lot of stuff for hip replacement. Just do you have any advice to use cemented stem versus uncemented? Is there any difference, especially in the complications rate?
Yeah, that looks like that cemented stems are safer in terms of survivorship, and probably because of periprosthetic fracture, and probably because of fracture during the implantation. So if you come from a high volume center and you are used with non-cemented stents, that's fine to use it in a good bone quality if you know the implant and you are used to do it. But if it's not the case, I would say that cemented stents are safer. So you have you diminish the chance to have a periprosthetic fracture. And we know, in technically speaking, it's easier to cement a femur than it is to cement an acetabulum. It's hard to do what these etc. guys do in the acetabulum part, and it takes time. So when you talk about cementing the femur, it's not very demanding technically. So I would advise you to do it. Choose a good stand. We have a few out there with good results, long-term results. So it's safer. I would, in a low volume hospital, I would advise you to use a cemented stand.
Awesome. That was the message I wanted to deliver. Using a cemented stem especially for the low volume surgeons, I think it's safer and carries a lower complication rate compared to a cemented stem. Thanks a lot. Thanks a lot, Lourenco. Yeah.
And that's funny. I don't know how it is in your places, but in Brazil we have some local industries. We have the public system, and their goal is to sell low cost implants. So I advise my friends, my younger friends who work in these hospitals with these low quality implants, because they have non-cemented and cemented stents. I tell them, I advise them to use the cemented because it's more, depends more on the surgeon, less on the quality of the implants. That's another point. That's for Brazil. I don't know how it is in your places, but I advise them because you are doing the best for your patient because it depends more on you.
That's true.
Yes. Got your point, Lourenco.
Oh, thanks for the answer. I think that's it.
Okay, thank you, Loy, for moderating as well. Lourenco, I think that's all the questions that we have for this session. Thank you for this very exciting presentation, and I'm sure this is going to reach a lot of people. Thank you so much for joining in.
Thank you very much. Nice to see you guys. Take care.